Welcome, everyone, to today's session of our Survivorship series led by Dr. Stephanie Berg. Today's topic will discuss bladder cancer and survivorship. This program is hosted by the Blum Resource Center. Over at the Blum, we are grateful to the Survivorship team for this continued partnership. The recording of this session will be posted on our Blum YouTube playlist and our Blum Digital Resource Center, as well as the Survivorship website. For those of you watching live, if you have any questions related to today's program, please feel free to utilize the chat feature throughout the session, and at the end, we will use those questions to moderate a brief Q&A. If you have any other questions or would like more information about resources and programs offered through the Blum, please visit our website at www.dana-farber.org/resource center, or you can email us at blum_center@dfci.harvard.edu. Thank you all for joining us. I will now pass the workshop over to Dr. Berg.
Hello, everyone. Good afternoon. So today we're going to be discussing bladder cancer survivorship, an overview of what to expect after you receive treatment for bladder cancer and how to bring up topics with your care team and some of the other things you might not have learned during your initial consultations. And so we can have this as a resource for everyone going through therapy. So let me see here. Here we go. So what is survivorship? So I think from, again, a cancer survivor, we think of a person from the time of diagnosis through the balance of his or her life. And survivorship, we define as the start of the point of diagnosis, recognizing that many people who live with cancer for years following diagnosis can remain well with support to address their needs as they arise. Survivorship also encompasses the physical, psychosocial, and economic sequelae of cancer diagnosis and its treatment. So a lot about what we're talking today will involve this and really understanding what it means to live with cancer, without cancer, or having had cancer, and how Dana-Farber and the Blum can support you. So outlined today, we're going to be doing a brief overview of bladder cancer. We're going to talk about the treatments you may have received and living with a urinary diversion if you proceeded with surgery for your bladder cancer, what follow-up testing after treatment means and new things that we've been doing in the clinic to look for cancer coming back, and also what survivorship clinic is and follow-up care. So what is bladder cancer? As we know, the bladder is an organ in the lower part of your abdomen. It's shaped like a small balloon and has a muscular wall that allows it to get larger or smaller. We know that urine from the kidneys passes through the bladder into two tubes called your ureters. The bladder is then emptying through another tube called your urethra. We know that there's 3 different types of bladder cancer, and these are the cells that we might discuss during your consultation with myself as a medical oncologist. They could be squamous cell carcinoma, transitional cell carcinoma, which is the most common type, and adenocarcinoma, which is the more rare common type. We know that cancer that is confined to the lining of the bladder is actually called superficial bladder cancer or non-muscle invasive bladder cancer. And cancer that begins in the cells that we described below with different cell types can spread through the lining of the bladder and invade in the muscle of the part of the bladder that actually contracts when you have to go to the bathroom. And this can also spread to nearby organs and lymph nodes. So at this point, we can say this is muscle invasive bladder cancer or invasive bladder cancer. But when it spreads to the lymph nodes or other areas, we would call it advanced bladder cancer. So where's bladder cancer lie in the United States? So it's actually the 6th most common type of cancer. There are over 83,000 cases estimated in 2023 with 16,000 deaths. It represents 4.2% of all new cancer cases in the United States. Data from 2017 to 2019 show that approximately 2.3% of men and women will be diagnosed with bladder cancer at some point in their lifetime. Also, by stage is important for bladder cancer. So as I mentioned before, when it's not invading, we call that in situ. So about 50% of cancers that are not invasive that can be treated with surgical approaches and other types of treatments inside the bladder are the most common types of diagnosis for bladder cancer. Otherwise, we can find it localized, which is about 1/3. And then the more distant or advanced stages are less, about 10 to 15%. We know that bladder cancer is diagnosed more in men than women, and that it is a cancer of, we say, the older population of 73. We know that the most common cause for one developing bladder cancer is actually smoking. So now about treatments and urinary diversions. So treatments specifically, again, for muscle invasive bladder cancer. So again, this is cancer that invaded into the muscle of the bladder. patients will be offered either surgery, radiation therapy, and chemotherapy. So surgery, we have different types. You might have received something called a radical cystectomy, which is a major surgery that you would have to have been admitted to the hospital for. And with that, when they remove the bladder, there's something called a urinary diversion of how they can redirect the urine from the kidneys out. So we can either, common ones include ileoconduit with stoma, or there's a stoma that the surgeons make, and you actually will have a bag on the outside of your body to collect the urine, or actually a neobladder or bladder substitute. So this is very important because living with urinary diversions after curative therapy for bladder cancer and how to maintain them is something that can definitely change your life, but it's easily managed. But some tips I'm going to go through about keeping an eye on them and how to manage that in the future. The other thing is radiation therapy. So radiation therapy is typically combined with chemotherapy for men and women that chose to preserve their bladders if it was indicated by their team. So there's also some light side effects of radiation therapy we'll go over. And then chemotherapy as well can be combined either before surgery or after surgery, depending on what your oncologist recommends. If you need more treatment after surgery or beforehand to achieve the best response for your cancer. So how does one live with a urinary diversion? So typically you would have had counseling from a nurse and how you can manage and care for your urinary diversion. We also want to make sure that you understand that you may still leak urine, particularly in the first 6 to 12 months after bladder substitute surgery. So at this point, using pads or briefs will be helpful during that time to ensure that your body gets used to the new way that you're making urine versus, a neobladder again, or a conduit. We know that urine leakage is common at night and in some cases continues beyond the first year after surgery. Also, dealing with urinary diversions, there's a lot of equipment that goes with it, specifically, again, when you have a stoma with an ileal conduit, meaning that you have to have a urostomy pouch. There's also, bags and supplies that have to go with it. So it's something about getting all that education before the surgery and afterwards and how to maintain it is really important to discuss with your care team. We know also that when you have urinary diversions, you can actually be at risk for infections. So bacteria can enter the urostomy and continent urinary diversions and cause this. So we know symptoms of an infection include fevers, chills, nausea, vomiting, poor appetite, back or lower side pain, frequent painful urination, and cloudy, dark, or strong smelling urine. So we do recommend that you drink 8 ounces of liquids each day or more to help prevent infection. So we really think it's important to stay hydrated when you have a urinary diversion. And please talk with your healthcare provider about urine testing to see if there's actually bacteria that you need antibiotics and when it's appropriate to treat an infection. So diet is really important as well, living with urinary diversion. So we always say to limit alcohol to avoid dehydration. You may also want to avoid certain foods that can cause the urine to have a strong smell, which may be noticeable when you empty your pouch. So we can also note that there's certain foods that can change colors that you might be afraid that your urine is a different color from your diversion, like beets or foods that contain dyes. And then also certain foods labeled here, asparagus, beer, fish, broccoli, garlic, again, can cause a very strong odor. So you might mistake that for a urinary tract infection when it was actually just something you had in your diet. And then certain medications are important to consider if they're, changing your color or odor of your urine that I have listed here, like vitamins, Kisara, metronidazole is a common antibiotic, also sulfa drugs, again, that can change your urine color. So just keep this in mind when these are prescribed to you, if any changes happen during the treatment. Another important thing about when you have a urinary diversion is about B12. So when you have a radical cystectomy and they make the bladder, they actually take part of your intestines called your ileum to kind of form the bladder, or they take that part out and then make your stoma to make your urine. So you might be low in a vitamin called B12, which should be checked at least yearly. And there are symptoms if you are deficient in B12, since you won't have the part of the body that absorbs it. We would recommend injections if you're not getting enough through your diet, or just taking higher doses of an oral vitamin pills to make sure that you don't develop any anemia, memory loss, dizziness, or mood changes that could be from B12 deficiency. So it is recommended that you get this checked at least every year and supplement it as possible when you have a urinary diversion. As well, we also say you may worry about how other people view your urinary diversion. Most people won't even know that you're wearing a pouch or have a urinary diversion unless you tell them. really just be in mind that you can choose to talk and how much information to share with the loved ones around you. I listed here multiple resources that are available, not only here at Dana-Farber, but also online that we participate in, like the Bladder Cancer Advocacy Network, the Urology Care Foundation, the American Bladder Cancer Society, and the United Ostomy Associations. They have really wonderful resources if you have further questions about living with a urinary diversion, other patients and people having, reports of what it's like, especially before going into surgery, after surgery, years after surgery, living with this. So it's really important to use these and, talk with your healthcare providers if you have any questions or concerns. Moving on to radiation therapy. So again, this is a technique that you might have had for treatment for your bladder cancer. Again, usually in combination with chemotherapy to treat. And it is something where we don't see a lot of immediate effects, more so than maybe some urinary tract infections or irritation in the urine. But what it does is that it can also kill the healthy cells along with the cancer cells. And we can see either in the shorter period after radiation quits, in the first couple weeks or even a few months later, that you can still have diarrhea, continued fatigue, occasional hair loss, nausea and vomiting, sexual and fertility problems, skin changes, and urinary and bladder problems. These are important to keep in mind because, again, you might have felt really well during the treatment and then might not realize that maybe a month or two later you start having these symptoms and wouldn't necessarily attribute to your cancer treatment, but it's important to bring up with your healthcare providers if you have any of these to see what we can do to treat these and discuss this and send you to specialists to help you manage these possible side effects. As what I give chemotherapy, we know that there are long-term side effects that can happen during chemotherapy. So chemotherapy, or we say chemo, again, was utilized in your care to stop the growth of cancer cells. So they either kill them or they stop them from dividing. So the way that we give chemotherapy is really dependent on the stage of bladder cancer. You might have received chemotherapy by an infusion. We rarely give it through the mouth. It's not usually a pill. Most of it are combinations of multiple chemotherapies. Ones I've listed here are the most common regimens we use. And this can, again, you might have received chemotherapy between 12 to 16 weeks or 9 weeks, depending on what your oncologist recommended, as well as chemotherapy during radiation therapy. We know that chemotherapy can also cause changes in your memory and concentration called chemobrain or chemofog. It can also cause chronic fatigue. It can lead to digestion and swallowing problems. It can lead to heart problems in the future, like damage to the heart and heart valves, swelling of your heart, blockage of blood vessels, and irregular heartbeats. It can also lead to peripheral neuropathy, which is a term that we say that has nerve damage. We can cause pain, numbness, and tingling and muscle weakness. It can also lead to ear ringing or hearing loss and rarely secondary cancers. So these are the symptoms that when you come visit your oncologist after your chemotherapy is done that you will get asked about. And please report them because we do want to monitor these for our survivors after chemotherapy to make sure we can either add medications to help, again, send you to specialists like the cardiologist, the heart doctor, if there's any heart problems, the GI doctors, if there's any digestion or swallowing problems, to really get to the bottom of it if this was a late-term effect from the chemotherapy. So here's some other possible long-term effects. Hot flashes can happen specifically, again, for women because during bladder cancer surgery, the ovaries would be removed. So that can definitely occur. Sex and fertility issues. For example, the prostate is removed for men during surgery for bladder cancer. The uterus is removed for women for bladder cancer surgery. So something to talk to your providers before going into this, especially if you are of childbearing age, of banking sperm for men and egg preservation, or using surrogates or things like that, because this is part of the standard care for surgical technique for muscle invasive bladder cancer. So it's really important to talk to your doctor about that. We know depression and anxiety are common, especially receiving surgery or treatment for cancer. These are important to note as especially finishing your therapy, to discuss with your provider and seek other help and talk with psychology or psychiatry during this. And urinary problems. I mean, you live with a bladder for all your life, and to have it removed because it had cancer in it is definitely a huge change. So we know you can have issues with leakage and incontinence, and there are ways to help and to fix this. And by talking to your urologist and your medical oncologist, they can definitely help you through that. So what do we do after follow-up for bladder cancer? So basic information that I give to my patients is that there are some tests that were done to diagnose or stage your cancer are usually repeated. This really helps detect any cancer from returning. So the biggest part about survivorship that we say in medical oncology and urology is making sure that the cancer does not return. So again, these are called follow-up tests or checkups. And this is something I, again, discuss about what is our action plan? What is the new normal after you receive chemotherapy or radiation therapy, surgery for your bladder cancer? And how are we going to make sure that cancer does not return? Because we know that is a big source of anxiety and fear that patients have. So we have new ways now to detect this along with standard guidelines from the National Cancer Comprehensive Network, or NCCN. So Dana-Farber is a NCCN site. So again, the NCCN is the National Comprehensive Cancer Network that develops guidelines for patients post-treatments for multiple tumor types. And here's an example of a chart that we use for men and women that had bladder sparing procedures, meaning that they went through chemotherapy and radiation, did not have their bladder removed, but again, still had a similar level of bladder, muscle invasive bladder cancer. So in this instance, you can see here on the left, we have their tests. So we have 4 things that we do during follow-up. The first one is called cystoscopy, and there's a schedule, and we usually, again, follow our survivors for up to 10 years. There's imaging that we perform. So the CTU or MRU is meaning like a CT scan or MRI scan, similar tests that you likely received before getting diagnosed with bladder cancer or how your bladder cancer was actually diagnosed. A CT chest is recommended to, again, look for cancer spread to other areas outside the pelvis where the bladder is located. And there's also something called a PET scan, which you may or may not have received before your cancer therapy, if your doctor thinks that your cancer may have returned in other areas. There's also multiple blood tests that we like to perform, looking again at your kidney function, your liver function, your blood counts. Specifically, again, when I discuss chemotherapy late-term side effects, we want to monitor these organs because when you receive chemotherapy, it does go into your vein. It does affect more than the bladder cancer cells that we are trying to attack. So we want to monitor these pretty closely. You can see here, we check these at least, 3 to 6 months during the first year. And then after that is clinically indicated, but we usually, again, check them yearly. And then there's also a urine test called urine cytology, which, again, if you have a normal bladder, we would not only go inside the bladder with cystoscopy, which I'll describe more in the next slide, but we also check the urine for cancer cells, again, at a very strict schedule for the first 2 years after therapy, and then as clinically indicated starting in year 3. So a little bit about a cystoscopy and cytology. So this is a procedure that, as a bladder cancer patient, you likely had to diagnose your bladder cancer, where they originally informed you that you had something abnormal in your bladder, where they took out and removed the tumor. So this is, again, where they insert the cystoscope in typically the urology office. And then a lot of times I remember my patients say you are awake during this procedure when it's in the clinic, and you can actually see the urologist on the screen, as here in this cartoon, looking at where the abnormality is in the bladder. And what, again, is it's inserted into the urethra inside the bladder. They fill your bladder with fluid, and then they look in the wall to see if there's anything that is abnormal. And then if possible, they might do a biopsy where they remove a small sample of cells or tissue so they can be examined by one of our pathologists to look for cancer. So if they do find a suspicious area, or what we say a mass or a tumor that's growing, they might have to bring you back into the operating room to do a more extensive surgery, or just take a small sample and see what is going on. So this is, again, a very standard procedure that we have for men and women that had bladder preservation or bladder sparing that did not go to surgery, to make sure that cancer is not returning. And if it does, they can take care of it right away. We also, at this time during cystoscopy, do cytology, which I mentioned previously, which is where the urologist will actually, when they put the fluid in there, they will actually kind of wash the bladder out, and then also take samples of urine afterwards to see if any of them look suspicious for bladder cancer. Even if they might not see anything specifically on the scope, there could be cells that were either from the upper part of the bladder, what we say the ureters, coming down from the part of the kidneys, to make sure that there's nothing abnormal. So again, that is a standard procedure that we do after bladder cancer treatment to ensure that we're checking for possible bladder cancer return. Guidelines are similar for men and women as well that actually have bladder removal. But as you can see here, there's no rule for cystoscopy because you do not have a native bladder anymore. Again, you would be given a urinary diversion with either an ileoconduit where you have, the stoma on your stomach and your lower abdomen where there's a bag to collect the urine, or a neobladder where the surgeons actually form a new bladder, and that's where the urine can pass. But the imaging, meaning the CT scans and MRI scans, are similar throughout this time course in that first 2 years as the men and women with bladders, again, using imaging every 3 to 6 months with the chest, again, looking for cancer coming back, anything abnormal like enlarged lymph nodes or anything that shouldn't be there. Again, looking at blood tests because a majority of men and women before surgery will receive chemotherapy. Some may receive chemotherapy after surgery. So really checking to make sure that none of these late-term side effects from chemotherapy on the liver and the kidneys and your blood counts are occurring, and we can monitor for that. As you note here, we have the B12 annually mentioned, as I discussed, because of the role of how your neobladder is made or your ileoconduit, monitoring that every year and supplementing it as needed, as well as urine tests. So the urine cytology or this urethral washing will be done by the urologist. And again, checking for bladder cancer cells in this area to warrant further workup and investigation if this is positive. So the newest thing that we have discussed in bladder cancer and cancer in general is what can we do outside of more invasive procedures like a cystoscopy and also radiation exposure using CT scans and MRI scans is actually doing blood tests. So this is just an example of one of the blood tests that it has become more common in the clinic that is performed by not only medical oncologists, but urologists and radiation oncologists. This is from a company called Natera, and the brand is called Signatera. So this is just an example of something called circulating tumor DNA. So there is a theory in cancer medicine that when you have cancer, the cancer itself can release small little molecules in your blood. And one of the ways that we can use this to perhaps detect that your cancer may be returning is to run special testing on your blood from your original cancer diagnosis. As we can see here on this chart, we can start monitoring for this even before your treatment starts for chemotherapy. And you can see here, you can get your surgery and then kind of detect in your blood, even before looking at it on your scans or seeing it in the cytology or the cystoscopy, that there could be cancer returning. Now, this is still experimental in a way because it is not FDA approved for detecting cancer after a definitive treatment, but it is something that is coming more so into clinical use and is very important for us as your doctors to have another layer of support to really answer, is your cancer returning? How can we find this earlier? How can we stop it earlier? What can we do with it? So I wanted to bring this up because if your doctor does talk to you about some of these tests that are coming up from diagnostic companies to really look at this earlier types of treatments needed for our survivors after cancer, it'd be really important to have a discussion with your physician about this and what it means for you and what it will and how it could benefit your therapy by doing this monitoring. Again, along with what we already discussed with national guidelines with imaging and the cystoscopy and the cytology, bringing this in for another layer during cancer monitoring. So one thing I wanted to emphasize is that once your cancer treatment ends, you really should receive a follow-up cancer care plan from your oncologist or someone on your treatment team. We think this is really important because when you're coming to survivorship clinic, or if you decide to perhaps transfer your care out of location or you needed to move, to understand what cancer treatment you received, what your stage was, what your chemotherapy regimen was, what complications you may have had during surgery. So that's something we do offer at Dana-Farber, that we easily provide our patients from our electronic medical record system, giving you this treatment summary. Again, there's a difference between a treatment summary and then your follow-up care. So I previously discussed what a follow-up care regimen would look like, including the different monitoring. But a treatment plan is something I think is really important to just have for you and for others, again, to make sure if you go outside of Dana-Farber or wherever care you are now, to understand what your cancer treatment was. Also, here at Dana-Farber in our survivorship clinic, we understand the needs as for emotional, social, and financial issues. So it's something we bring up when we discuss our survivorship and what we can do to help our patients, because we understand that can be a lot to go through, and how it's important during your cancer survivorship care to really bring your team involved with all your needs. So here's some general tips I would say for all of our cancer survivors. Specifically in bladder cancer, we say the number one thing is to quit smoking. We also say cut down on how much alcohol you can drink, just again to prevent dehydration. We think eating a balanced diet and plenty of fiber is something that can be really helpful in your survivorship care. We don't know exactly which foods are better than others, but we always say that if there's any questions that you have, a dietitian referral is the best option, especially again, if you are living with a urinary diversion, there might be certain foods that are specifically worse for you going through that in the beginning. But again, most people can have normal diets though after their surgery. We also emphasize to exercise and stay active, about 30 minutes each day. This can help reduce anxiety and depression, improve mood and boost self-esteem, and reduce fatigue, nausea, pain, and diarrhea. So these are some things, again, that talk with your doctor, talk with your care team about when you're in this different, new normal, as we say, after your cancer treatment, to really help you move forward and, again, still follow up to that I described before with your care team. So here's our website again for our survivorship program. I just wanted to kind of summarize our bladder cancer survivor needs. Looking at cognitive support, follow-up is really important. We know that bladder cancer is something that can return. It is something that close follow-up with that imaging and those other methods I noted are extremely important with your care team to do in that first 2 years, to really make sure we have a good action plan if something were to happen after your therapy. Recognizing the side effects that your therapy had, there's always a difference between when you're going through it and what happens after everything is done. Making sure that you have good care planning afterwards. Also looking to your primary care doctor, so we don't ignore the fact that after having bladder cancer, to update your yearly mammogram, colonoscopy, and low-dose CT scans for, if you are a smoker, for lung cancer screening are really, really important. Also understanding your quality of life, having a different, especially going through surgery, what that means for you. Psychosexual therapy, again, for fertility issues and libido issues are really important to discuss with your provider. Diet and nutrition, again, seeking care for a dietitian, using our resources here if you have any questions about that. Maintaining exercise if possible to stay healthy. And then again, getting back to work and living with post-cancer treatment, what that means and how we can help you. That is it.
Thank you so much. This was a really great presentation. It does not look like we have any questions in the chat right now, but feel free to ask any questions in the chat or the Q&A. And while you may be typing those in, I do want to remind you that you can find the recording of this on our Blum YouTube playlist, as well as our Blum Digital Resource Center and the Survivorship website. So be sure to check it out, as well as our other Survivorship series videos that we have. All right, we're getting some thumbs up, some clapping. So I think we are all set. Doesn't look like there's any questions. So thank you so much again. This was a great presentation. Have a good one.
Thank you.